Thank you for joining and still being here. I am Micah Kuntz, Research Supervisor of the Investigational Drug Team, and today it's my absolute privilege to introduce two of my favorite people here at Cook Children's, two leaders who embody what it means to push the boundaries of pediatric medicine for the sake of every child. Dr. Anish Ray is a pediatric hematologist and oncologist, the medical director of the IRB, and the program lead and recipient of the Endowed Chair for Precision Medicine. Dr. Heidi Trinkman is a clinical pharmacy specialist for Cook Children's Medical Center. She specializes in hematology, oncology, stem cell transplant, and cellular therapies. She was recently promoted to the Advanced Therapeutics Program Manager. Over the past 12 years, I've got to work with these two. I've witnessed firsthand how Dr. Ray and Heidi have not only championed the use of genetics-informed, precise care for our oncology patients, but have also built something extraordinary, the Precision Medicine Program, which is now recognized with the honor of the Endowed Chair. In 2019 and in 2020, they established the weekly Molecular Tumor Board and monthly Precision Medicine Conference. These gatherings have only grown in impact and attendance. They bring together clinicians, pharmacy, researchers, medical students to collaborate and design a treatment plan for each individual patient. They come up with a plan A, a plan B, and a plan C that are based on these patients' tumor markers, previous treatments, open trials, and available medications. I can count on them day and night to answer my questions, and I know their patients feel the same. So it's with great excitement that I welcome Dr. Ray and Heidi to share more about how precision medicine is currently impacting care and where they will take this program next.
Thank you so much, Micah, for that kind introduction. Thank you to the research department for allowing us to come here and showcase our work with all of you. Heidi is one of the most prolific and bright individuals I've ever known. This really started about more than 5 years ago, pre-COVID, when Dr. Valance asked us to start a molecular tumor board, which was a monthly thing, and I didn't know where to start. And so, as all things, I went to Heidi and said, Heidi, how do we start this thing? And she said, well, okay, so we got together, and when she and I will sometimes look back at the last 5 years, it really seems like we've come a long way, but then we also realize how much further we have to go and make sure that the precision medicine type of approach goes and touches the life of every patient, every corner of the hospital. So I will get started. We want to stay on time, and we have quite a few slides to go through. I'm going to get started, and then Heidi will follow as well. So here is a breakdown of the objectives. We will talk about the fundamentals of precision medicine as we understand it from a cancer standpoint and non-cancer as well, apply precision oncology to our cancer patients, examine pharmacogenomics in pediatric care. Heidi is going to discuss that part, and then we'll talk about some future vision that we have about non-oncology partnerships and applications of precision medicine throughout the hospital. All right, so here is a breakdown of the agenda for this presentation. We will start with universal genetic testing, which, by the way, is still not considered standard of care in a vast majority of children's hospitals in the United States for children with cancer, and we are actually at the forefront in using these methods as standard of care for newly diagnosed as well as relapsed patients. And we will talk about some of the hurdles associated with interpretation and application. Then we will talk about capturing all the results in an accurate manner, and then embracing and taking all of this learning back to the patient, and then looking into the future as well. Okay, so what is precision medicine? I think first things first, starting off with the definition, there is a well-recognized definition as introduced by the NIH and recognized by the FDA. It is the branch of medicine that departs from the one-size-fits-all approach for treatment, and it accounts for individual differences in genes, environments, and lifestyles. So in simple words, we want to identify most of our patients in this quadrant where the drug prescribed is beneficial yet not too toxic for the patient. So again, what does it mean in a real-world experience? Think of Emily, who is an 8-year-old girl who has asthma and has been prescribed a standard inhaled corticosteroid as is standard, or Emily, who is 8, has asthma with frequent exacerbation, has been prescribed a combination of inhaled corticosteroids and a long-acting bronchodilator. Or Emily has actually undergone what we call a pharmacogenomic testing that has identified a certain genetic variant in her genetic makeup, and this genetic variant is associated with known reduced response to beta agonists like albuterol. So her pulmonologist, keeping all of this in mind, has individualized her treatment plan to now consist of a different class of anti-asthma medication, and has also provided adequate education to the family on trigger avoidance. That makes sense? Okay. Everybody's vigorously nodding. Mission accomplished. All right, precision oncology. So if you look at this graph here, along x-axis we have time, along y-axis we have proportion of patients surviving or identified as long-term survivors. And we saw a similar presentation at Dr. Stigall's presentation last night, which really is a highlight of the benefits of conducting research in a systematic manner. But the dramatic success we have seen in children diagnosed with any form of cancer in the United States and also outside, and the improvement we have seen over the decades clearly we must congratulate ourselves for this great work done, but also the families who have participated in these research trials, so that we can now safely predict that over 80% of children diagnosed with any form of cancer, any stage, can expect to have long-term survival outlook, which is phenomenal. However, is it enough to say that the job has been done, or has the job been done well? If you look at what is left behind is a large population of survivors who are really carrying what we would describe as a survivor's burden. So we have created a large group of patients who have survived their tumors and they're alive, and of course that was the first order of jobs, but we have created survivors really who I don't think would consider themselves as contributing members of society for a variety of healthcare burdens that they have to carry. Remember, these are children who are diagnosed with leukemia and other malignancies early on in their lives. So at ages of 3, 4, or 5, who has expectedly another 75, 80 years to live and will be carrying all of these problems, which can involve their heart, which can involve their hormonal systems, their cognitive behavior, mental health. And then as they grow older, how they would participate in the workforce and how they would relate to the rest of society, etc., are very important. Secondary malignancy is a very important problem. I met this young woman this morning, a lovely 20-year-old woman who was diagnosed with lymphoma when she was 15, completed treatment, and now has a second malignancy, probably because of the chemotherapy medications that she received as part of her primary malignancy. So imagine the disappointment. Like, she has gone through chemo, she's been through jail, she is looking forward to the best part of her life, and yet she comes in and we tell her, well, we've got cancer again, and this time we don't think it is curable. It is such a letdown. So what can we do to help improve the situation? So looking at cancer, our understanding before and now, previously we would direct the diagnosis of cancer towards the tissue of origin, as all of you are probably aware: prostate cancer, breast cancer, colon cancer, brain cancer, etc., associated with significant adverse effects when we have administered chemotherapy to our patients. New knowledge, not so new anymore actually, over the last 25, 30 years, is that tumors are driven by what we describe as driver mutations, which can be targeted to suppress the neoplastic proliferation. Here's an example of a classic mutation involving the RAF pathway identified in patients with malignant melanoma. And I could have listed here one of 100 different mutations that have been well described in the last 5, 10, 15 years. But there's a reason why we have highlighted the BRAF V600U mutation, which is almost exclusively found in adults with a certain type of skin cancer known as malignant melanoma. With that being said, there is increasing realization that cancer is not one disease, but many different diseases. By the way, these magazine covers are from like 20 years ago. Yeah, that's when the copyright thing went away, so I could just freely download and not acknowledge anyone. But we have also understood that individuals have unique tumors and treatments should be kept that in mind. In 2001, or towards the end of the 1990s, really, we had two landmark discoveries. One was in chronic myeloid leukemia with the discovery of imatinib, which really made an incurable disease into a very easily controllable disease known, with the use of the drug imatinib, and we have several improved generations of that drug now, as well as the discovery of HER2 and the target of HER2 with trastuzumab in patients with breast cancer, so that the treatment outlook, if you look at even like advanced stage patients with breast cancer now, is tremendously different and positive compared to even 5 years ago. All right, so why now? Several different things have happened. The field of biology has seen an explosion in terms of all the information that it is generating nowadays with greater understanding of the human genome and its sequencing, but also information technology has undergone so much improvement that it is now possible to look at large amounts of data and make intelligent information out of that to apply to individual patients. Case in point is terms like artificial intelligence and ChatGPT have become household terminologies. Now, I'm guilty of the same as well. Frequently it is available and gives you an intelligent answer if you have a complex question. All right, so looking at the last 5 years of FDA drug approvals for hematology and oncology, again, I want to remind all of you that whichever specialty you practice in, your approvals from the FDA are more than likely to look exactly the same way with different names for different mutations. So if you look at leukemia drugs that are listed here, blinatumomab, rituximab, these are all well-known agents. You look at tyrosine kinase inhibitors, these are all specific drugs that are targeting specific proteins as a result of specific mutations. And then gene therapy, as Dr. Stigall mentioned yesterday, has revolutionized the cure for patients with sickle cell anemia. These patients are pleasantly surprised that they're not having to wake up every morning with the fear of getting yet another bout of vaso-occlusive crisis and another 5-day stay at the hospital, which disrupts not only their lives, but also the lives of their parents and families around. All right, so then moving on to some case examples, I think these are most important because these are vastly different tumors, treated differently, managed differently, but my question to you is, can there be a common theme that sort of connects these three cases, besides the fact that they're all involving children with tumors? So this is a 6-month-old infant who was treated here at Cook by Dr. Hein. This child presented with a large swelling lower extremity. As you can see, this abnormality here is the mass. This was biopsied and the diagnosis came back as infantile fibrosarcoma. Conventional treatment would have required intense chemotherapy, radiation therapy, as well as surgery, which potentially above the knee amputation could be debilitating for this child. The second case is rather curious because this is a 12-year-old child diagnosed with a rectal adenocarcinoma. Why is it curious? Because this is an exclusively adult onset disease. This is a family that had immigrated from South Korea, and this child was diagnosed here. And conventional treatment, again, would have included intense chemotherapy with the goal to shrink the tumor, followed by surgery and then radiation to secure negative margin. So close your eyes for a second. If you have any idea as to what radiation feels like, or you have any perception of what it might look like, and having that in your rectum for 28 days, it is the most painful experience that one can think of. Okay, lastly, something very different in nature. This is an 18-month-old child who presented with fever, generalized rash, with shortness of breath. On scans was found to have a large chest mass as well as multiple bone involvement. This was biopsied, and the results came back as Langerhans cell histiocytosis. Again, conventional treatment for such multisystem involvement involves chemotherapy, but we have come to recognize that about 50% of patients, despite being treated with chemotherapy, can sustain an unfortunate relapse. All right, 3 very different diseases in children, different types of malignancies, but the underlying treatment that we would have offered to these patients 5 years ago would have been intense chemotherapy with or without radiation and surgery. All right, so keep these in mind, and we are going to come back to these 3 patients subsequently. All right, so moving on to interpretation and application, we had lofty goals of precision medicine and pediatric oncology, but to break it down simply, our idea was to help improve outcome, decrease side effects, and perhaps then also decrease the cost associated with delivering care. With that being said, how easy or difficult is it to embrace precision medicine and sort of be adventurous and step out of your comfort zone and areas of learning? Who needs help? Do the families need help? Patients? Do the doctors need help? Do we need education for our department, for ourselves, for our community, so that we can then go and advocate for the patients? So some strategies to overcome. We thought of molecular tumor board as I started off in 2019 when Dr. Valance came to us and first asked us to start a molecular tumor board. We started off with lots of visions. We wanted to roll out comprehensive tumor profiling and decide on the clinical relevance. We wanted to access local and nationally available treatment options for our patients, enroll patients on clinical trials, provide genetic counseling, and all sorts of lofty goals. And then we came to the harsh conclusion that there were lots of problems with the reality. There were problems with provider knowledge. All of these sequencing reports were complex. They were very long, 15 to 20 pages if you've ever looked at them. And they used technology that we had not really learned so much when we were in school. Next generation sequencing, whole exome sequencing, sequencing of DNA or RNA or both. What should be done? Nobody was there to guide us. And once you ordered these tests, then you looked at the report. And then the report was even more perplexing. There were lots of genetic abnormalities described. There were variants of unknown significance. We didn't know how to act or interpret those. And then we also did not know how to embrace or look at the therapeutic options. There would be reports that would have recommendations based on tumors, telling us to use medications that have, one, not been studied in children, second, have not been studied in a pediatric condition. So let's say the FDA has approved a drug for colon cancer patients, an oral drug, studied in patients who are 65 and above. And if you are asked to apply this knowledge for your 6-year-old who does not have colon cancer and is not 65, but has a very pediatric tumor, the question is, well, should this be considered in isolation or in combination with chemotherapy? And so with all of these questions came a lot of uncertainty, discomfort, and a general tendency to avoid, reluctance to order these tests, which really ended up being a disservice for all of us, patients and providers alike. So what we did is we wanted to get together in a room and share all of this. Can we get together and we can address all of our lack of knowledge and overcome some of these hurdles? We could not solve this in the isolation of our offices. And then the practical issues is, well, are we selling false promise to our patients? Are we telling them that if your child went on this drug, which has barely been studied in children, are we subjecting them to unknown side effects? And so are there any ethical concerns associated with such practice of medicine? Is it safe? Or is it rogue? So here is our molecular tumor board. Again, started off with Heidi and I, and then we went and recruited others. Molecular pathologist Dr. Jason Wang has been our supporter, and I call Jason Wang all the time with all kinds of questions because he is such a wealth of knowledge, and he can share all of that and explain things that require us to act upon certain abnormalities versus not. Also, the research department attends all of our meetings, and they will remind us if there is a clinical trial that's open and enrolling, whether at Cook or elsewhere where patients may actually be enrolled. We have geneticists as well as genetics counselors who join our meeting because some of the findings will tell us that a patient may have a genetic predisposition to cancer, such as Lee-Fraumeni syndrome. Dr. Valance recently gave a grand rounds where she talked about the genetic oncology clinic seeing all these patients with cancer predisposition. And then last but not the least is the role played by medical students. And we have a separate slide dedicated to the super role played by students who actually research these reports and make a crisp presentation every Thursday at 2:30. If you're interested, we would be happy to join that call as well. Really fellow level presentations by these fantastic medical students representing both medical schools in town. All right, so we started this was once a month, and we quickly realized that there was a lot of pent-up demand for these tests, and quickly there were a lot of patients who had undergone testing and we had not discussed them. So then we needed to meet more frequently, and we started meeting once a week. And this month, we have gone from discussing one patient a week to about 2 to 3 patients because the backlog is tremendous, and more patients get added to this tumor board discussion. So here is a breakdown of the services that got started, and in that order we started off molecular tumor board, which is monthly, and then the precision medicine consultation service that meets once a week, and we discuss all of these patients with medical student participation, and we generate a report that then goes into the chart and becomes a part of the patient's medical record. But also pharmacogenomic testing has become such an integral part of the precision medicine component of things, especially over the last 12 to 18 months, and then Heidi will explain more to you. But here is a breakdown of the sequence of events. Child comes in, is diagnosed with either a new onset malignancy or a relapse of previously known malignancy, and the tumor is biopsied. Our pathology colleagues will give us the diagnosis, and then we will also arrange for the sample to be then sent out to one of our commercial partners who will perform their end of the work through next generation sequencing. And the report will arrive to our desk, and we will start working on researching the findings described in the report, and then we meet on Thursday afternoons through the molecular tumor board that we just looked at, and then generate a modified, finalized version based on everyone's feedback, and then that report becomes part of the patient's record. All right, so role of medical students in precision medicine clinic. We are historically not a teaching hospital, but we teach so much, and actually it is right for us to acknowledge that medical students teach us the most. If you are ever attending any of these meetings, they put their heart and soul into these presentations. We have had more than 50 students present since January of 2022 in over 120 meetings. And so one of the questions that came up from the students 2-3 months ago is, well, Dr. Ray, I see that you are using us as free labor. What is it for us in this? So they, they sent out a survey to all the participants, medical students over the years, and said, what good has this done you? And so this survey told us, the students actually said that they learned about new technologies, new methods to interpret complex reports, made themselves aware about precision medicine, where medicine is headed, but they also became more confident in choosing a specialty of their choice as they were getting ready to apply for residency, etc. And so this then became a paper that I've squeezed in here, describing the students' experience of participating and helping foster our precision medicine clinic. All right, so moving on to the database. How are we doing on time? So one of the important things about testing these days is that it generates a large amount of data. And so what do we do with all of that information? We started a database back in 2019-20, which has really become large now. Here are some of the pieces of information that we capture, including tumor types of patients, demographic information, test details. It is important to know what type of sample has been sent to the lab, whether it is blood or tissue or both, DNA test has been done, or RNA, and so on. And then what mutations have we captured? Is it a point mutation? Is it an insertion, deletion, etc.? What is the clinical relevance of these results? And what is the application? Because we can capture all of the data we want. If the doctors are not using this for their treatment of their patients, it is probably no good. All right, so looking at the embracing of treatments, of course, you would not be surprised that radiation, surgery, and chemotherapy remain the cornerstone of treatment of malignancies. But we've had quite a few patients who were treated with targeted therapy, either in isolation or in combination with chemotherapy, which is quite encouraging. And here is a breakdown of all of the mutations, and I don't expect you to appreciate all of these changes in tumor mutations, but suffice it to know that these mutations described as driver mutations are different in children than they are in adults. If we never looked at the sequencing information for children, we would never know what is unique about pediatric tumors. So that's where the first step is to seek knowledge that would apply to the unique group of patients we take care of. And so based on these mutations, here is a breakdown of some targeted agents that have been used, and we have described our findings in several papers that we will share with you over the years as well. But it has been a great learning experience, and I think we have added significant value to the lives of these patients. All right, so then quickly, I want to introduce you to what clinical trials look like nowadays. You may have heard of most trials, even 10 years ago, would have been, well, this patient has small cell lung cancer. Here is a group of medications that we want to try, phase 1, 2, 3 trials that produce some results, and we go to the FDA and say, can you approve this drug for this particular indication? Come 2022, this trial was actually open at Cook. It was a large multi-institutional consortial trial, but I want to point out this very first trial listed on the top is an NTRK fusion, which is an abnormality detected in certain tumors, and the drug associated with it. So essentially what we're looking at is a tumor-agnostic approach to clinical trials. If you have this mutation in your tumor, you may qualify to participate in the study, and you may qualify to receive this monoclonal antibody or a tyrosine kinase inhibitor. It is a major deviation from how medicine has been tried, tested, and practiced over hundreds of years. So when the FDA approved not larotrectinib, but its earlier cousin entrectinib in 2019 or 20, it was a landmark moment because it was the first ever drug approved by the FDA not based on a tumor type. It said if you have an NTRK mutation, regardless of the cancer, regardless of your age, regardless of your gender, you will qualify to benefit from this medication. So that was, again, an early indication of which way the field is moving. And so what about trials here at Cook that are not part of multi-institutional trials? Remember, at the very beginning when we were describing how we look at cancer nowadays, we talked about a mutation that's exclusively found in patients with malignant melanoma, which is an adult exclusively adult disease, but also we have come to recognize that the same pathway involving BRAF V600E is also activated in patients with a very pediatric condition known as Langerhans cell histiocytosis. And so the question came up, well, can we utilize some of the lessons learned from treating patients with melanoma and apply those for the treatment of children? And at the time when we started to discuss, and we were at Histiocyte Society meetings, and some of us would bring this up, we were looked at as like, you are crazy and your license should be taken away. However, science has continued to progress despite all skepticism, and so we decided to roll out a trial, again working closely with Micah and Heidi, in identifying a pediatric dose for these patients, which ended up being a very low dose compared to the melanoma doses for patients with LCH. And so going back to the third case that we talked about, this 18-month-old with fever, chest pain, rash, etc., this child was initially treated with 4 cycles of chemo and had progressive disease, as highlighted here with the red circles, was switched to trametinib, again a drug borrowed from treating melanoma patients, and look, after treatment this child's tumor has dissolved without the side effects of chemo. So I'll give you a moment to digest that, and then moving on to our broader experience of treating children with trametinib. I put down here 16 patients, that's actually 19 as of today, and we have had a 100% remission rate of treating these patients with our own trial. And the adverse effects have really been tolerable, mostly rash that goes away after holding drug for a day or two or going down to a lower dose level, diarrhea, etc. And then we have also managed to capture all the mutations. Moving back to the first case we talked about, the 6-month-old with the large tumor in his thigh, who would have received chemo radiation surgery, perhaps even amputation, was found to have NTRK fusion and was treated with entrectinib, which is the first FDA-approved TRK fusion related drug, and this is an oral formulation, treated for 6 months as a liquid, and tumor went away, melted away with really no change in lifestyle for this infant or his family. So big win there. And then lastly, I want to make you aware of immunotherapy. You may have heard of immunotherapy being available for certain patients with colon cancer and lung cancer. The idea is there are several mechanisms by which tumors will evade the immune system, mostly through the expression of PD-L1. And so once we start immunotherapy, by blocking those antigens, we are able to bring the lymphocytes back into the tumor environment. And we applied this for this child, and dramatic response noted as well. All right, so here is a video that I think I'm going to skip in the interest of time, and we can come back to it if we have time. Moving on to the most important part of our endeavors is with pharmacogenomics. Over to Heidi Trinkman.
Well, the good thing is I don't, yeah. He'll be back. He'll be back. It's okay. I only have a couple of slides just because I can't talk nearly as quickly as Dr. Ray can. But I will say that I get asked a lot about what pharmacogenomics is, what am I doing is different from what Dr. Ray is doing. It's still sequencing genes, right? Well, it's actually, I tell people the same thing except different. What he is doing is looking at the genetic information, the genetic mutations within a tumor, within a malignancy, and then applying targeted therapies to that. What I am doing in pharmacogenomics is we actually are looking and sequencing genes from the germline. These are those genes that are inherited from mom and dad. And those genes looking for variations in genes that we know have something to do with how drugs work in your body. And so we look for those variations that impact either whether a drug is going to work or not work in your body, or whether it's that genetic variation might put that patient at risk of potential toxicities associated with it. So what we decided to do with a pharmacist and a dream, we decided to start a pilot study here and see if we could do it. Was it feasible? Is this something that we can do here? And so we had Epic build us an inpatient and an outpatient consult, as well as it grew exponentially from there. Basically, now we have the genomic module and clinical decision support based off that. So it's gotten really crazy from there. But we designed the service to really be around a 2-visit approach. So the first visit, when we're consulted on a patient, the first visit is a sit down with the family and telling them and educating them, this is what pharmacogenomics is, this is what it can tell us, and this is what it can't tell us. What are the limitations of this science at this point? Because some people come looking for answers that pharmacogenomics just can't provide for them. But we can tell them where the benefits are and how that can help them. And then if they choose to move forward with it, then we put in the order. We send about 3 to 5 mils of whole blood and get it sequenced and then say, we'll see you in about a month. The turnaround time is anywhere between 2 and 3 weeks, but that gives us a little bit of wiggle room depending on how full our plate is. And then that second visit is when we sit down with the family and we go over any of those variations that are found that impact medications. We educate them on what medications are involved and how their particular patient, their family member, those variations can impact the medications and what we need to do about it. So this is just a list of, there's 76 different medications that are impacted by the 26 different genes that we sequence on our panel. We chose to go with a panel because it's nice and broad and, look at all you get for pretty much roughly about the same price as doing one gene. So we chose to go with this panel, 26 different genes sequenced and 76 different medications that are impacted. And these aren't just specialty medications. Yes, there are some anti-neoplastic medications for chemotherapy, but there's things like NSAIDs, there's things like PPIs, there's things like pain medications. There's a lot of supportive care on this list. And so I like to tell people there's a little bit of something for everybody, right? So this panel can really cover a wide range of patients. So we started back in March, the beginning of March of 23, and we launched our little pilot study, and specifically in the oncology patients, because that was the world in which we worked, and that's the patient population we know, and that's a patient population that unfortunately sees a lot of different medications. And so we really focus on doing the first visit in that lab inpatient is preferred, but we do have the ability to do ambulatory visits as well. So we made sure of that. But we've done, and I went up till about November of 2024, so about a year and a half's worth of performing this service. And we've done, at that point, 164 consults. And looking at our patients, let's see. This is just kind of a broad looking at the number of actionable findings. So those are the variations that we found that we need to act upon. And on average, it's about 6 per patient, right? We have some patient that had 13 different gene variations. That's half the panel that we look at, right? So it's actually been very impactful. The number of things. Think about what you would miss if you were only looking for one particular gene because of one particular medication. So having this information is very important because we can then proactively counsel those families on what they need to avoid and these sorts of things, what we need to be looking for. We've been, of course, we were focusing mainly on the HEMONC group. So yes, 80% of our consults have come from the HEMONC group, which was what we were intending. But the word got out, and we did take some consults from some other areas, things like genetics. They had parents calling, wanting pharmacogenomics being done on their kiddos, and they were like, "Can you do this, please?" And so we said, "Yes, absolutely, we'll do that." Pain service has utilized our services as well. So now we're at the point where we're ready. Our infrastructure is built solid enough for us to now be able to offer this house-wide. So we will be going to each area, really kind of targeting what this can do for your patients. This is, as every good pharmacist knows, the CYP enzymes are the workhorse of metabolizing drugs. And the one thing I really want to point out to you is for HEMONC, right, the CYP2D6 is going to be the gene that is associated with Zofran efficacy. And we had identified 6 of our patients who were ultra-rapid metabolizers who Zofran won't do squat for. And so that's important to know before we give them chemotherapy, don't you think, right? So this just kind of driving home some of the benefits that this can bring. We've identified some patients who are at risk of vincristine neurotoxicity from this, and these HLA findings, these are more associated with toxicities. And we've identified patients that are at risk of toxicities, significant toxicities from carbamazepine or life-threatening toxicities from abacavir, and one with the potential of toxicities with allopurinol. And then these are just some of the other genes that we look at, things like SLCO1B1. A quarter of our patients had this particular finding where it could impact how they process statins. And the way that we counsel these patients is this information is good lifelong. It's not going to change from now to when you're 50. So even though they may not be needing cholesterol, meds now, they might need these in the future. And so it's good to have this information. It's good to know so that they can prepare for better dosing for medications and selection in the future. All right, so now I'm going to throw it back to Dr. Ray.
Okay, Taya is threatening me with a 5-minute warning, so what I'm going to do is let others speak. A picture is more than 1,000 words. So I took a process improvement lesson with Dr. Shernette Kidd and her team, and I learned about terms such as voice of the customer. So I can pat myself in the back as much as I want, but it doesn't mean anything until the patient is actually benefited or not. Clearly, patient has benefit, that's why we put this up. So there's no surprise. Let's see if this would work.
Hi, I'm Amanda Parsons. I'm the mom to Mackenzie, who was diagnosed with LCH, which is Langerhans cell histiocytosis, when she was 6 years old. So Mackenzie was complaining of back pain. That was our first sign that something's not right. We have been a patient now at Cook Children's for 4 years. Mackenzie was diagnosed, and it was a very fast-paced environment after that. A lot of specialists and doctors, and then we met with our oncologist who talked with us about starting chemo straight away. She had a port placed, and she was super sick, not feeling well, and it would take her weeks at a time to even get back to the person she was. When she was on chemo, she was kind of just a shell of the little girl that we knew.
Hi, my name is Mackenzie Chapa, and I was diagnosed with LCH. My experience with chemotherapy was terrible. I couldn't do anything, and I just had to sit there and be bored doing nothing, just looking around me, wondering what will happen if I stop taking chemo. And so it just kind of made me...
Chemo had done its job by getting rid of the tumor, but at that point her spine was in free fall. The tumor was holding her spine together pretty much. So then we went into emergency surgery. We were getting our halo on, and it turned out that Kenzie was a candidate. She was going to be able to start taking a pill and no longer have to come up here and get the chemo. We didn't know what that journey was going to look like because it was so different than what we had been doing, but we had hope that it was going to be a better route. Mackenzie's daily life on targeted medicine is night and day from when she was on chemo. She is smiling, she's laughing, she's playing with her friends, she is not sick. Nothing compared to the debilitating state she was in when she was on chemo.
I really like my targeted medicine because I can do more things now than I could with chemo. The one thing I'm looking forward to this year is just like living a normal life and having as many sleepovers as I can.
Mission accomplished. All right, Tia, are we good? I will finish ahead of time. We could have, well, we have a few minutes. Okay, so really such an approach need not be restricted to cancer only. We have forged some early partnerships with our friends in the Department of Genetics. Dr. Campbell and Dr. Carrasco also have interest in this area. Dr. Carrasco in particular is interested in building a gene matcher program whereby patients who are chronically ill, have complex conditions but without a clinical diagnosis or undergo genetic testing, and based on the findings, those patients can be connected to scientists who are working on those particular genetic abnormalities. We have also looked at our partners in nephrology. Dr. Gillespie is spearheading a precision medicine type of approach with the recognition that 50% of pediatric chronic kidney disease has a genetic basis, and 30% of nephrology patients have some sort of underlying genetic abnormality, and specific gene-based therapies are becoming available not just for your sickle cell and hemophilia patients, but also for kidney disorder patients. And so this is a slide I borrowed from Luke, actually. Along x-axis, you have knowledge. Along y-axis, we have severity. And as one would expect, oncology features high along both axes with increased knowledge, but increased severity from exposure to chemotherapy. Those are toxic drugs, the public knows. But also other specialties are coming up, including neurology, immunology, etc. Immunology, we want to make a separate case because the number of genes that are associated with inborn errors of immunity have actually exploded in the last 10, 15 years. Hundreds of genes have now become available, as opposed to just describing them as patients with abnormal genes predisposing to infections, etc. So really this is a passion dream of Dr. Stigall, but also Luke Hamilton and his department, where they view precision medicine as having two major arms, a diagnostic and a therapeutic arm. But the goal is really to diminish the time to arrive to a proper diagnosis, and then moving the patient over to the therapeutic arm, where patients would receive appropriate gene-based or mutation-based therapies with fewer side effects and hopefully better quality of life. So with that being said, we've had quite a few papers that we have published in the last 2 or 3 years, and we have presented our good work at national conferences as well. These are mostly with the help of Natalia, who has been a fantastic medical intern. She's finished medical school and will start residency in July, and she has become one of the experts on LCH, and I think this is a great platform actually to train the doctors of tomorrow here at Cook Children's, who will then come back perhaps to work here, or at least will describe their experience with their colleagues, and Cook Children's will really the name will spread. And so here is how we view it, with research being in the center, and there are several arms that are pointed out here. There is Dr. Valence's Genetic Oncology Clinic, the General Cancer Clinic, Pharmacogenomics, and clinical genetics, as well as non-oncology, which would really be the other specialties, including nephrology, immunology, etc. All right, so that brings us to the end. We have completed 75 slides. We can take questions.
Dr. Ray and Heidi have successfully avoided questions as well.